And welcome to the Dr. Bob Show. Has your doctor ever ordered an x-ray, chest x-ray, and then called you back and said, I need for you to come in and let's talk about your chest x-ray. There's a spot on your lungs. We'll be spending most of the show talking about a solitary spot on the lungs. We call it a coin lesion or a solitary lung nodule. My guest is Dr. John Martin Prince. Dr. Prince is a board-certified pulmonologist, lung specialist, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about aneurysms in the abdomen. What does that mean? And heel pain, that old enemy, plantar fasciitis. What causes it? Is it really plantar fasciitis? And what needs to be done? A lot of information for you. You'll want to stay tuned. We're talking with Dr. John Martin Prince, board-certified pulmonologist, lung specialist. Marty, welcome to the Dr. Bob Show.
Great to be here, Bob.
What kind of training do you have to be a board-certified pulmonologist?
Well, pulmonologist is a subspecialist in internal medicine. So you basically train as an internist, and then you do a fellowship in pulmonary medicine after that.
When you're a board-certified pulmonologist, how often do you look at abnormal chest x-rays?
Every day.
And if that chest x-ray shows a spot on the lungs, that's what we're going to be talking. What do you think of when you see a spot?
Well, there are lots of different causes for spots or nodules on the lung. So when you see a spot on the lung, you have to sort out what this means for the patient. Is this going to be a lesion that is risky or dangerous for them? Or is this something that is a benign process? So you have to kind of go through a process of assessing the lesion, the characteristics of it, and then look at the patient and decide what is this person's risk for having something bad in that nodule or spot on the lung.
So the two different type of patients that you wouldn't be necessarily as worried about, but concerned, versus pretty concerned.
Correct.
What would be what kind of people?
Well, in general, older people are more likely to have cancer, which is what you're concerned about with a spot on the lung. People who have habits that put them at risk for having cancer, specifically smoking cigarettes, are concerning. So an older smoker is a high-risk patient. A young person who's not been a smoker would be considered a low-risk person.
So if we look at a spot on the lungs, is the size make any difference? Does the shape make any difference? What characteristics of that nodule are important?
There are several characteristics we look at. If you have a small nodule, less than 4 millimeters, which is tiny, a quarter of an inch.
That's sort of like the end of a eraser on a pencil.
It's very small. A small nodule that is well circumscribed or well defined is less concerning than a larger nodule that has irregular borders or is what's called spiculated. It's sort of like a star shape.
So we don't want irregular spiculated borders. We want a nice smooth border. We want a little nodule rather than a big.
That's
How about calcium?
Calcium is helpful in some situations. You have a nodule that's completely calcified, it's densely calcified, so it's very, very regularly calcified. It's usually benign. Calcium in other patterns is not as helpful, so having a little calcium at the edge of the lesion doesn't make it a benign lesion, so you have to follow those.
So what I'm hearing is it's very, very important that you take the history, that you look at the patient, you know in your mind what the risks are, you look at the x-ray, the spot on the lungs, you make an educated guess on what to do about it. If they've got a spot, 35 not risk, 70 big risk.
Right.
What's the next step in both of them?
Well, the next step is to find out, does this person have older imaging studies? If someone has a chest x-ray from 2 years ago, that shows an identical lesion, then you don't do anything because it's not grown. And if it doesn't grow, it's not of concern.
So if we have a chest x-ray 2 years ago and we have one now same size, then you say, well, let's watch it, let's pay attention.
You would pay attention to it to some degree, but you don't have to have a detailed, prolonged or invasive evaluation if something's been there for a long time.
What if they hadn't had a chest x-ray in 10 years and they can't find the one before that?
If you don't have old imaging studies, then you have to make the decision based on the things we talked about: the patient's risk profile, the appearance of the lesion, and things like has this person been at risk with smoking, that sort of thing.
So if there's anything suspicious in the history or the appearance of the chest x-ray, what's the next step you do? You have to take it out? What do you do?
The next step for a nodule on a chest x-ray is you do a CT scan of the chest, which is a computerized tomography. It's a special type of x-ray where a patient's imaged in a scanner, and it generates a series of slices of the chest, kind of like a loaf of bread.
So it walks through the lesion.
And you can identify whether that's the only lesion, and it gives you a whole lot more information about size and characteristics such as calcification and that sort of thing.
So if the x-ray, what you're looking for is other spots that don't show up on the regular chest x-ray, and then you walk through that lesion. If you're still suspicious, any other x-rays help you?
In certain situations, so what we would end up doing, if you have a lesion that is large in a high-risk patient, you probably will go ahead and, if they are surgically acceptable candidates, not at high risk, take that lesion out because you're concerned enough that the odds of that being malignant are high enough that watching it or doing other things doesn't make sense.
So you go in and you get a piece of it. Now how about, before we would get to that, does a PET scan show you anything? In the,
PET scan is very useful for intermediate sized lesions in people who are sort of intermediate risk, because that scan looks for tumor cells. And if the lesion is big enough, greater than about a centimeter in size, in somebody who's got intermediate risk, you can look at the PET scan. It's particularly useful if it's negative.
So if it's negative, it helps you. If it's positive, it may not be?
If it's positive, you have to still continue to follow that person, because other things, infections or inflammation, can cause a PET scan to be abnormal.
This PET scan is really looking for a lot of blood vessels that are in an area. And a cancer has a lot of blood vessels around, is that right?
There are a lot of blood vessels there, and it's rapidly growing or metabolizing tissue. So this tissue is active. So tumor cells are active, and PET scans picked up that kind of activity.
And so the PET scan, if it, quote, lights up, that's maybe a bad sign, but it's something you have to continue.
That's right.
Now, when you talk about a biopsy, is that difficult on a patient?
I've never had one done myself, but for most people, it's not a very, they don't describe it as being an uncomfortable experience.
How do you know whereabouts you've had the CAT scan, so you know
right
right
where
it is?
You can locate the lesion from the CAT scan.
So do you open up the chest or you get a needle biopsy? What do you do?
Part of it depends on location. If you have a nodule you want to biopsy, and it's just on the edge of the lung, right up against the chest wall, so it is near or touching the chest wall, then it's really simple and low risk to have a radiologist take a look at that with a scan. They numb up the side of the chest and put a small needle in there and get tissue out. That's low risk and is not particularly uncomfortable, and is a good way to get diagnostic material.
Now, do you ever do bronchoscopy? Do you look at the bronchial tree? Can you go through the bronchial tree to get a biopsy if you have in the middle of the
particularly chest? Lesions that are central or kind of in the middle of the chest. You can do a bronchoscopy and use a fluoroscope to guide a biopsy force through the airway itself and out into that nodule.
Now, if the pathologist finds it's benign, then it's fun to talk to the patient, isn't it?
It is a good thing to say. Well, when we do these biopsies, if they find a diagnostic material that tells you a specific answer, like this is an infection, then you can tell that patient you don't have to worry about this being a cancer.
And if it's a bad-looking cell, then we have to approach it differently. Is that correct? And that's what we're going to be talking about. What if the biopsy comes back an abnormal lesion, very suspicious of a cancer? What do we do? You'll want to stay tuned. We'll be right back. We're talking with Dr. John Martin Prince, board certified pulmonologist. We've been talking about a spot in the lung. It depends on the risk of the patient, whether they're young, non-smoker, old smoker, what the lesion looks like, if it's irregular and spiculated versus very smooth surface, how big it is, if we get a biopsy and it comes back normal or abnormal. Marty, let's talk about, I want to drop back a little bit now, and let's talk about why cigarette smoking is such a risk to people, and what are the current recommendations of smoking. So what does smoking do as far as cancer?
Well, smoking is by far the largest risk factor for developing a lung cancer. And if people have smoked for more than about 25 to 30 years, then you're at risk. And a lot of our population, people start smoking young. So when people are in their mid-30s, they're at substantially increased risk for developing lung cancer, and that increases with the amount they smoke and with the number of years they're still smoking.
So we go, what does the pack year smoking history mean?
A pack year means that if you've been smoking 1 pack a day for a year, that's a pack year. So if you smoke 2 packs a day for a year, you have a 2-pack year history. So it's basically calculated in that fashion.
But I don't inhale.
Of course, no. Everybody inhales.
So how about if you're in a house where somebody else is smoking? Does that put you at risk also?
That puts you at an increased risk, not nearly the risk of being an active smoker, but there's the passive environmental tobacco smoke exposure is a documented risk for lung cancer.
Are you seeing more and more problems with lung cancer in older people who have been smoking with a 25-plus pack year history?
Yeah, that you definitely see more disease the longer people smoke.
And when you see that, that's made our screening recommendations different in the last 2 or 3 years. What are the current recommendations on screening for lung cancer?
The current recommendations are to look at people who are at risk, which is defined as being 30 pack years of smoking, and who are in an appropriate age group between age 55 and 75 to 80. And if you have those 2 things, then it's recommended that you have a low dose, which means a low radiation type of CT scan once a year to screen for cancers.
Is it a high definition CT or just a CT of the chest?
It's a CT of the chest, and it's done with a lower energy or low radiation exposure to
And
the
so
patient.
what we're trying to do is find a little small spiculated nodule that's there that you can't even see maybe on a chest
That's
X-ray.
right, because you can see these things sometimes well before you can see them on X-ray, because the CT scan looks at the lung in sequences of slices, whereas the chest X-ray takes the entire chest, and nodules can be hidden behind structures like the heart, and you don't see them clearly.
Have you seen people with that the CT of the chest picked up a cancer that wasn't there?
It's a very common thing, actually.
So it's common. So that screening is very, very important. Because if you find a solitary nodule early and you take it out, what does that mean to the patient?
Well, it's a really good thing. If you find something early and you can resect it, then most of the time that patient's cured from their cancer. Now, an important point about that is if you find this in someone and they continue to smoke, then they're highly likely to get another cancer, and they may not be able to be resected once they have had more than one resection. They lose their lung function. So a key part of screening people is encouraging people not to smoke. And that's actually way more cost effective than doing scans, having people try to quit smoking.
If you tell them you got a cancer, you got to stop the smoking, that pretty much is a call to stop that smoking. It's a
absolutely.
very difficult thing to do.
It's extremely difficult addiction to stop, and people who have really good intentions will have a lot of trouble sometimes. But the key is to be persistent and try and try again. Most people who want to quit smoking do. Over 1 million people a year quit smoking.
Over 1 million people will stop smoking. It's so important. We see cigarette smoking causing cancer in other places and damaging blood vessels. It's just a terrible thing. We could never bring cigarettes to the market now. It'd never pass the FDA, in my opinion. There's that.
Sure shouldn't.
So screening, chest X-ray, we can cure if we find it real early in some people, if they stop smoking, you take off that lesion.
In most people, yeah.
Let's go back to that little nodule on the chest where we got a biopsy and it was negative. Does that mean we have to stop worrying? Let's say 42-year-old that smoked 10 years ago and they had a little nodule. How do you approach that?
Well, in that person, if you've done a biopsy and the biopsy shows non-specific findings. In other words, you don't get an actual diagnosis. They don't find a fungal germ in there or a TB germ or some other specific finding. That person needs to be followed and continue to look at this individual and either make a decision to take that nodule out or to do serial scans over 3 or 6 or 1 year periods.
Depends on the patient.
Depends on the patient. A higher risk patient, you screen more often to make sure that this lesion stays stable for 2 to 3 years, depending on its characteristics.
You know, my feeling is, Marty, that when you've got a little nodule there or a big nodule there, that it needs to be in the hands of a board-certified pulmonologist who does this all the time and can guide. How frequent does the patient have to have surgery?
Well, it depends on what happens as you follow them. If a nodule is enlarging, then if they can tolerate surgery, that needs to be taken out. That is because even if you don't have the diagnosis ahead of time, you'll get the diagnosis and treat the patient at the same time. If someone is extremely frail and a high surgical risk or simply doesn't want surgery, then at that point in time, you will make an effort to get a diagnosis if you can without surgery and offer them some other treatment like radiation therapy if they have a diagnosis of cancer made.
Now, I know some people that have had lung cancer that have done so well, and the pulmonologists do such a good job of guiding people, you know, where that they can do the very best they can. You know, my hat is off to you. This is such a scary thing to people and such an important part of taking care of a patient. Marty Prince, thank you for coming to the Dr. Bob Show. You're a great, great teacher, and, you know, thank you for teaching people.
You're welcome. I appreciate being here.
Okay. If you've had a chest x-ray that's abnormal, be sure that it's followed by a board-certified pulmonologist who can guide you toward what needs to be done. And the chances are, if it's a solitary single little nodule, that you've got a good prognosis. Be sure that you see that doctor. And now you're going to want to stay tuned. We're going to be talking about aneurysms in the belly. What do they do to, and heel pain. Is it plantar fasciitis or is it something else? A lot of information for you. You'll want to stay tuned. I want to thank Dr. Marty Prince. Wonderful discussion on solitary nodules in the lungs. Find it early. You may have a cure even if it's cancer. Now for questions from you, the viewer, that I think are important to your health. Dr. Bob, I have heel pain. I'm a 42-year-old teacher and it hurts like mad in the morning and I have to limp all day. Well, those are classic findings of plantar fasciitis. It's usually in younger people. It's in ballerina dancers, it's in teachers, it's people that are walking around frequently during the day. It's people that may have a high arched palate or they may have flat feet, and the pain is on the heel. But the problem is at the bottom of the foot there's a fascia that attaches to the heel, and that's where the inflammation occurs. That's where the pain occurs. And when people wake up in the morning and they get out of it hurts to step on the floor. So they begin to rub their foot and massage their foot and slowly put weight on the foot. What it is, it's inflammation right at the end of the heel there, plantar fasciitis. What can we do? Well, when we wake up in the morning, we can stretch our foot. We pull the toes back. We massage the bottom of the foot. We start resting as much as we can. We might have to get an x-ray to see if there are calcium spurs that may be aggravating that. We can go to a physical therapist, and the physical therapist can maybe use ultrasound, or they can use heat, or they can teach you how to exercise. There are special shoes. There are splints that you can use at nighttime, and they all keep the toes pulled back. And that will help relieve some of the pressure on plantar fasciitis. It may last 4, 6, 8 weeks. Sometimes it keeps coming back. Sometimes, and very rarely, and almost never, you need to have surgery that takes away those little tears that are in the bottom of the fascia. But in general, it's splints, it's ibuprofen, can be massage, can be ultrasound. But if it's bothering you longer than 2 to 3 weeks, be sure and see your doctor. Be sure that your doctor has you utilize physical therapy and go by expert means of getting that plantar fasciitis better. Question number 2, Dr. Bob, what is an aneurysm in the belly? Well, it's obvious that this person has been told that they have an aneurysm in the abdomen. Now, what's an aneurysm? An aneurysm is just where the blood vessels, the arteries, have a weakness in the wall, and it begins to balloon out. It's usually secondary to hardening of the arteries. That's usually secondary to people that have smoking or elevated cholesterol or high blood pressure. Those are the things that cause people to have weak blood vessels. You can have aneurysms in blood vessels in the brain. If they burst, then we have bleeding into the brain. Coming out of the heart, the aorta, we can have a thoracic aortic aneurysm. If it bursts, boom, we bleed out. Going further down at the aorta in the abdomen, if we get an aneurysm there, if it bursts, boom, we've got 2 to 3 minutes before we bleed out. So it's very, very important. What do we do? Well, sometimes a screening test after a certain age, or if somebody has been a smoker, or if somebody has high blood pressure, or if somebody has hardening of the arteries, we'll get an ultrasound of the abdomen. And if it finds an aneurysm, a ballooning out of that vessel, then we've got a couple of things to do. We look and see if it's enlarging rapidly over a period of repeated again in 3 months, or whatever the doctor says, or if it gets above 5.5 centimeters, that's a little over 2 inches in size, then we consider doing surgery on that. So it's a real touch and go situation, because that's a weakness in a large blood vessel that's nourishing the rest of the body. So you have to follow that very, very carefully. Now, what kind of surgery is done if you have to have surgery? Well, in the old days, we used to make a cut in the abdomen, and we would bypass that area. We would simply put in a tube that bypassed that aneurysm, and we could take that aneurysm out and use the connector tube to hook up. Now we can go in intravascular. We can do with a catheterization. We can go into that part of the vessel. We can open up a balloon, not a balloon, but more or less a slinky inside there. And that slinky will then begin to develop a normal lining and a normal flow of blood, and that aneurysm will no longer be there, and we don't have to worry about that. It's a sign that maybe you've got vascular disease that needs to be looked at. So if you're smoking, we'll have to stop smoking. If you've got high blood pressure, it needs to be under control. If your cholesterol is high, you must take medicines to get that cholesterol under control. And so it's very, very important that you follow your doctor's orders to get your cholesterol low. We can exercise. That will help bring down the cholesterol, but usually it takes medication. If your blood pressure is high, we can exercise. That will bring down the values of your blood pressure, and there are excellent medications to do that. If you're smoking, we need to set a date to stop, find a friend to stop with, go to an organization like the American Lung Association that has smoking cessation classes. And then there are medicines that you can use to help substitute the nicotine. If you're smoking, please stop. It's going to harm your health. That's all the time that we have for this show. Remember, we want to be exercising every single day. It lowers that blood pressure, it lowers that cholesterol, it lowers stress, it makes you feel better, it makes you happier, you'll get a runner's high. It needs to be 5, 6, 7 days a week, and it needs to be 45 minutes to a whole hour. And remember, eat properly. Eat more fruits and vegetables. You know, what we eat is what we are. And if we start eating better and less amounts of food, we'll find that weight begins to drop, that our health gets better, that we feel better. 8 hours of sleep. Now they're saying maybe just 7.5 hours sleep. And you'll feel refreshed the next day. If you're not sleeping well, talk it over with your doctor. Maybe you don't know how to go to sleep, or maybe it's a sleep disorder like snoring, or the other person in the bed snores, or you've got restless leg syndrome, or narcolepsy, or you've got sleep problems, insomnia. So if you've got sleep problems, talk to your doctor about it. But most of all, what do we like in the Dr. Bob Show? It's that giggling and that laughter in your life. If you laugh a lot, there's no question you'll be healthier.